Welcome, everyone. Let's jump right into this explainer on navigating psychiatric and behavioral emergencies in the emergency department. Now, the ED is a high-stakes arena, right? And when a patient arrives in the middle of a psychiatric crisis, it immediately demands some serious medical detective work from us. Our job today is to unpack the source material and figure out exactly how to distinguish a true psychiatric emergency from a deadly organic disease that's just wearing a clever disguise.
So here's our roadmap. We'll start with a welcome to the ED. Then move through triage and initial assessment, hunting for organic disasters, managing agitation and restraints, complex profiles and legalities, and finally, the final disposition. Let's get to it.
Welcome to the ED. So, psychiatric emergencies are an absolute staple of every emergency department. We see them all the time, often at disproportionately high rates in homeless and incarcerated populations. But here is something that might surprise you. Their shortened life expectancy? It's actually largely driven by untreated and comorbid physical illnesses, not the psychiatric disease itself. There are deadly organic masqueraders out there. Think meningitis, sepsis, delirium, and trauma. And then there are toxicologic and metabolic traps, like DKA, acetaminophen toxicity, myxedema, hepatic encephalopathy, and NMS, all hiding right behind behavioral symptoms. So here's your golden rule for medical clearance. If you see new onset psychosis or altered mental status in a patient with absolutely no psychiatric history, you literally must assume it's an organic disaster until proven otherwise. We also see stable scenarios, of course, like incidental chronic illnesses or treated conditions. But that golden rule? Keep it front of mind.
Okay, Section 2, Triage and Initial Assessment.
From the second a patient walks in or arrives with EMS, the initial chaos has to be immediately structured into a strict protocol. It's a 5-step journey. First the arrival, then immediately screening for weapons, conducting a high-risk triage, moving into the actual assessment and observation, and finally determining their disposition. It's all about transforming a totally unpredictable situation into a highly structured clinical pathway.
Now, when EMS gives you advance notice, that is a vital window. Use it to get security, nursing, and medical staff completely prepped. Your absolute first priority? Screen for weapons ASAP. Patients need to be placed in a room completely free of any objects or liquids that could be used for harm. Get them undressed and into a hospital gown right away. EDs use various triage flags to quickly identify high-risk threats, things like protective custody, precautionary holds, specific chart flags, or even distinct gown colors to flag patients who are suicidal, violent, or an elopement risk. You really need to dig into the history here: symptoms, severity, timing, provoking features. And perhaps most critically, because the patient themselves might be uncooperative or altered, you must openly ask about substance use and aggressively hunt for collateral information from family, police, or EMS. To safely interview a potentially volatile patient, you need some highly strategic techniques. Always know your exit locations and stand near them. Keep your distance, wear a breakaway badge, introduce yourself, establish eye contact, and try reusing the patient's own word to build rapport. You want to start open-ended and transition to close-ended, keeping yes, no, or multiple choice as a total last resort. But we also have to talk about common assessment deficiencies. These are the dangerous pitfalls that lead to failed medical clearances. We're talking incomplete histories, missing collateral info, ignoring abnormal vital signs, or entirely missing life and limb threats like a narcotic overdose. Other huge traps: doing cursory physical exams, anchoring way too early on psychiatric diagnoses, or resorting to indiscriminate kitchen sink lab testing while failing to continually reassess the patient.
Moving on to Section 3, Hunting for Organic Disasters.
A solid history alone can uncover a massive share of underlying medical emergencies. You need to watch out for these specific historical red flags. If a patient has absolutely no previous psychiatric history, has been recently hospitalized, or shows signs of infection, red flag. What about recent medication changes, sudden changes in behavior, or visual hallucinations? Huge red flags. Same goes for extremes of age, a new onset seizure, recent memory loss, or a history of substance abuse. When you hear these, your radar should immediately go off. These are loud, blinking warning signs that you are dealing with a medical, organic issue, not just a behavioral one.
And that brings us to the physical exam. A comprehensive, head-to-toe, trauma-style exam is literally the cornerstone of medical stability. Abnormal vital signs are a massive red flag. You've got to obtain them ASAP and always recheck them before discharge. A fluctuating level of consciousness, a clouded sensorium, or a GCS of less than 8, that is an absolute emergency. You're also hunting for focal neurologic findings, like new seizures or a sudden inability to walk. Look for ophthalmologic abnormalities, like rotary nystagmus, and evidence of trauma.
Think raccoon eyes, battle sign, or septal hematoma. Don't forget abnormal dermatologic findings, like a rash, purpura, jaundice, or uremic frost. All of these, along with an abnormal mental status exam or visual hallucinations, mean you've got an organic disaster on your hands.
When you're doing your review of systems, or ROS, you want to avoid overly open-ended questions that just lead to a massive over-endorsement of symptoms. Instead, use targeted yes or no questions for things like fever, cough, rash, and trauma. Then there's the mental status exam, which is basically expected by inpatient psychiatry. This assesses everything from affect and attention to language, orientation, memory, and visual spatial conceptualization. Now let's talk labs, because this is a big one. The high-yield information actually comes from your history and physical. Routine labs are generally incredibly low yield, even though, yeah, a lot of psych facilities still demand them if they lack on-site testing. And remember, your initial assessment is just a snapshot in time. You must continuously reassess. There are 4 main triggers for this: decompensation in the ED, evolving withdrawal or overdoses, coexisting medical needs like needing insulin or blood pressure meds, and finally, hidden medical disorders that are just starting to reveal themselves.
Section 4. Managing agitation and restraints.
5. That is the golden number of staff required for a violent restraint. You need 1 team leader and exactly 1 person for each limb. Honestly, sometimes just a poised show of force with a team of 5 can actually subdue a patient without ever needing to make physical contact. But when de-escalation feels and physical restraints are necessary for self or staff protection, it becomes a strict, non-negotiable process. You have to keep the patient and family informed with clear explanations. Then secure all 4 limbs with leather restraints, and you absolutely must elevate the head of the bed to minimize aspiration risk. Once restrained, offer medications. If they refuse, you administer them involuntarily. The legal mandates here are no joke. You have to know the time limits, renewal orders, and documentation rules. You must continuously check vitals, airway, skin integrity, and range of motion. And legally, that very first face-to-face assessment is required within 1 hour. When the patient is finally calm, removal is stepwise. You take off just 1 limb at a time.
To manage all this, we use the Sedation Assessment Tool, or SAT, to scale our chemical interventions. If a patient is at a +3, meaning they are combative, violent, and out of control, you're escalating straight to physical restraints and intramuscular injections. Typically, that's lorazepam 1 to 2 milligrams IM plus haloperidol 5 to 10 milligrams IM, or you might use olanzapine or droperidol. Now, as the score drops to a +2, very anxious, agitated, loud, or a +1, anxious, restless, talkative, you can often transition to oral medications if the patient is actually willing and able to take them. A score of 0 means they are awake, calm, and cooperative, so obviously no escalation is needed.
All right, Section 5, Complex Profiles and Legalities. Let's talk about high ED users. They're sometimes unfairly stigmatized, but the reality is they usually have complex chronic illnesses, trauma, and really poor support networks. For them, the ED serves as a default safety net that provides real emotional benefit. Actionable social interventions like supported housing and care navigation actually reduce recidivism, and since their cognition is often impaired, you want to use simplified, single-focused follow-up plans. We also have to be aware that unconscious provider bias alters care, so strictly adhering to protocols really improves quality. Now, what about involuntary admission? The strict legal criteria require all 4 of the following elements: a severe disorder, a need for inpatient care, a safety necessity, and a prospect of recovery. That last one is huge. It excludes patients whose only issue is intellectual disability, autism, or substance use. When placing a hold, it falls into 3 specific categories: harm to self, harm to others, or deterioration without treatment. And crucially, enacting this requires 2 distinct sources of information, like a police affidavit combined with a family or social worker's report.
Now, let's look at a critical legal distinction that every single ED provider absolutely must master: capacity versus competency.
It's a common trap, but they are very different. Capacity is a clinical determination made by a healthcare provider. It is decision-specific, time-specific, and highly dynamic, meaning it can literally change rapidly during a single ED visit. It basically assesses if the patient understands the risks, benefits, and alternatives right now. Competency, on the other hand, is a legal determination decided by a judge in a court of law. It's global, extending to financial, health, and personal matters, and it is not dynamic. Its absence usually implies a legal guardian is involved. Oh, and competency is not the same as the power of attorney. Conflating capacity and competency can cause massive legal headaches, so keep them straight.
Finally, Section 6, the final disposition.
Getting to that final disposition requires rigorous evaluation, selective testing, and often psych consults. It can be a really frustrating bottleneck. If you're discharging a patient, you must consider things like housing insecurity and whether they can actually afford their medications. For admissions, the main limiting factor is a severe bed shortage across the board. Alternately, brief observation is super useful for fast-resolving substance intoxication, though keep in mind it does add to your length of stay and liability. But here's the really tricky part. Psych facilities can have incredibly strict exclusionary criteria. They might refuse a patient based on pre-existing medical conditions like pregnancy or an inability to manage comorbidities like peritoneal dialysis. They might demand specific labs regardless of actual clinical need, or even block transfers over logistics like roommate gender matching requirements. ED staff have to know these local exclusionary criteria inside and out. Otherwise, patients just end up boarding endlessly in the emergency department.
Okay, we've covered a lot of ground. So it's time for our high-yield rapid recall. This is the ultimate, rapid-fire synthesis of the most critical data from this explainer.
Let's lock this in. New psychosis or altered mental status with zero psych history, that is organic until proven otherwise. A good history identifies the most significant medical pathology. GCS under 8, absolute organic red flag. A violent restraint team requires exactly 5 people, 1 leader, 4 limbs. Restraint reassessment must be face-to-face within 1 hour. SAT +3 agitation means IM lorazepam plus haloperidol, or olanzapine/droperidol. Involuntary holds legally require a severe disorder, inpatient need, safety necessity, and a prospect of recovery. The hold categories are simply harm to self, harm to others, or deterioration. And finally, capacity is clinical and time-specific, while competency is legal and global.
We'll leave you with this thought. How will mastering this chaotic intersection of medicine, psychiatry, and law completely change the way you view the very next patient who walks through the ED doors? Medical clearance isn't just checking boxes on paperwork, it is literally life-saving detective work. Thank you so much for joining me on this explainer. Keep this framework in mind, and you'll be ready for absolutely whatever comes through those doors next.